The main pulmonary artery originates from the right ventricle. It divides into left pulmonary artery and right pulmonary artery, which in turn further subdivides into segmental and subsegmental branches. Respiratory gas exchange takes place at the pulmonary capillaries over the alveoli. Oxygenated blood is returned by pulmonary venous system, which drain into the left atrium by 4 pulmonary veins, right and left, superior and inferior pulmonary veins. Pulmonary circulation is a low resistance system. Pulmonary arterial systolic pressure is about 1/5 of the systemic arterial pressure. Hence, right ventricle is a thin-walled chamber in the adult compared to the left ventricle, which faces the systemic circulation. In fetal circulation, right ventricle is dominant. Pulmonary vascular resistance is high prior to the functioning of the lungs. This is a pulmonary angiogram obtained by injecting contrast dye into the main pulmonary artery. Catheter, that is a small tube, was introduced into the main pulmonary artery through the right femoral vein. Pulmonary angiogram shows hypoplastic main pulmonary artery and right pulmonary artery. Upper branch of right pulmonary artery is not visible, and so is the left pulmonary artery. A small stump of left pulmonary artery is visible. Fetal circulation is different from adult circulation. Changes occurring soon after birth constitutes transitional circulation. Respiratory gas exchange in the fetus occurs in the placenta rather than the lungs. Fetal cardiovascular system is designed so that most saturated blood reaches the heart and the brain. Fetal circulation can be called a shunt-dependent circulation because there are intracardiac and extracardiac shunts. Cardiac output in the fetus is called combined ventricular output. Despite the low oxygen partial pressures in fetal blood, presence of fetal hemoglobin and high combined ventricular output helps in the oxygen delivery to the tissues. Fetal blood returns to the placenta by the umbilical arteries and returns back to the fetus by the umbilical vein. More than half of this bypasses the hepatic circulation through the ductus venosus and reaches the inferior vena cava. Streaming of blood from the ductus venosus with saturation of 80 to 90% is separate from the desaturated blood returning from the lower part of the body. Eustachian valve at the junction of the inferior vena cava and the right atrium directs this saturated blood to the foramen ovale and into the left atrium. Left atrial oxygen saturation is about 65% in the fetus. This saturated blood passes into the left ventricle and is ejected into the aorta. Major part of this blood reaches the cerebral and coronary circulation. Desaturated blood from the superior vena cava, coronary sinus, and the remaining part of the inferior vena caval stream is directed across the tricuspid valve into the right ventricle. Only around 12% of the blood ejected from the right ventricle reaches the lung due to high fetal pulmonary vascular resistance. Rest of it crosses the ductus arteriosus and reaches descending aorta. So lower body gets relatively desaturated blood. Part of it goes to the placenta through the umbilical arteries for oxygenation. In the fetus, 65% of venous return reaches the right ventricle and 35% reaches the left ventricle due to the shunts. About 45% of the combined ventricular output is delivered to the placenta, while the lung receives only 8%. Soon after birth, lung expands and lung liquid is cleared. This leads to a marked fall in pulmonary vascular resistance and increase in pulmonary blood flow. The fetal right ventricular dominance changes to the left ventricular dominance over a period of time as the right ventricular mass regresses and left ventricular muscle mass increases to support the systemic vascular resistance. Increase in pulmonary venous return raises left atrial pressure and the valvular foramen ovale closes. Ductus arteriosus starts constricting on exposure to the high oxygen saturation in blood after birth. Ductus venosus also gets obliterated. Transitional circulation is relevant in congenital heart diseases. The closure of ductus arteriosus in the early neonatal period can lead to marked fall in the oxygen saturation in cyanotic congenital heart disease with low pulmonary blood flow. Maintaining ductal patency with prostaglandin infusion or ductal stenting is often resorted to as a bailout procedure in such situations. There is a similar role for maintaining ductal patency in ductus-dependent systemic circulation as well. Similarly, a restrictive foramen valve leads to desaturation in transposition of great arteries. Here comes the role of neonatal balloon atrial septostomy in dextrotransposition of great arteries. In case of atrial septal defect, significant left-to-right shunt is usually not established soon after birth. Maximum shunting occurs when the right ventricular mass regresses and right ventricular compliance increases. That is why the clinical diagnosis of atrial septal defect is often delayed beyond early infancy. Even with ventricular septal defect and patent ductus arteriosus, the full establishment of the left to right shunt is delayed a few weeks, awaiting the regression of pulmonary vascular resistance. That is why these lesions may not be picked up clinically soon after birth and needs follow-up evaluation so that they are not missed. Closure of both ductus arteriosus and ductus venosus is delayed in preterm infants. Prevalence of patent ductus arteriosus increases with increasing prematurity. It is said that the premature ductus responds poorly to oxygen and more to prostaglandin. Clamping of the umbilical cord after delivery leads to a 30 to 50% decrease in venous return. Here are the initial set of journal references. Few more journal references are here. Ductus-dependent circulation is one in which a patent ductus arteriosus is useful in maintaining the circulation after birth. It is important to rule out such conditions before any PDA closure is planned. PDA-dependent circulations can be PDA-dependent pulmonary circulation, PDA-dependent systemic circulation, and PDA-dependent mixed circulation. The first group includes pulmonary atresia, tricuspid atresia, and tetralogy of Fallot with pulmonary atresia. In those cases, postnatal physiological constriction of ductus arteriosus can cause severe hypoxemia, cyanosis, and even death. In these cases, there is severe restriction of pulmonary blood flow and pulmonary circulation is dependent on a PDA. Second group of conditions with severe restriction of systemic blood flow include severe aortic stenosis, coarctation of aorta, interrupted aortic arch, and hypoplastic left heart syndrome. Postnatal constriction of PDA can cause systemic hypoperfusion, shock, metabolic acidosis, and death. In the third group, as in transposition of great arteries, both systemic and pulmonary circulations are dependent on adequate mixing as both circulations are in series. Maintaining a PDA is one method of providing mixing between systemic and pulmonary circulations. In all these situations, ductal patency can be maintained by prostaglandin E1 infusion as a temporary measure till other procedures can be done. Continuous infusion is needed as 60 to 80% of PGE1 is metabolized on first pass through the lungs. Initial palliation in transposition of great arteries can be with balloon atrial septostomy followed by arterial switch operation at the earliest. Two main ways of managing those with other varieties of ductus-dependent circulation after the initial prostaglandin E1 infusion are stenting the patent ductus arteriosus and modified Blalock Taussig shunt. Multicenter trials have shown equal mortality endpoints for both methods but reduced morbidity for ductal stenting than modified BT shunt. Recovery times are shorter and requirement for extracorporeal membrane oxygenation (ECMO) is lower with ductal stenting. There is also improved quality of life with ductal stenting, but the main limiting factor is the longevity of the stent. A systematic review and meta-analysis comparing PDA stenting and surgical aortopulmonary shunts concluded that both had similar mortality, but there was shorter hospital stay, shorter duration of mechanical ventilation, and fewer complications with PDA stenting. They found more patients with pulmonary atresia and intact ventricular septum with expected biventricular repair undergoing PDA stenting.